Welcome everyone to our webinar this evening on this snowy evening for many of us. We are thrilled to present Palliative Care and Breast Cancer, a partnership with Hospice of Central PA and funded by Aetna Better Health of Pennsylvania. And we're honored to have Dr. David Wenner and Dr. Maria Olender of Hospice of Central PA presenting our webinar this evening. I know many of you will be receiving continuing education an hour for this activity, so we want to make sure you have this information. This continuing nursing education activity was approved by the Pennsylvania State Nurses Association Approver Unit, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. In order to receive your one continuing education credit, you must answer all questions on the evaluation at the end of the webinar, and that will pop up once we've completed. And then your certificate will be emailed to you after completing the survey. So without further ado, I'd like to hand it over to our PA Breast Cancer Coalition President and Founder, breast cancer survivor, Pat Halpern-Murphy. Pat?
Thank you, Natalie. And I'd like to thank both Natalie Kopp and Abby Piskel from the Pennsylvania Breast Cancer Coalition staff for doing all the technical work and putting this webinar together. Thank you. Now, welcome to all across Pennsylvania who have joined us this evening. We've had over 200 people express interest in participating in this webinar on palliative care and breast cancer. And I know Natalie is in the snowy part of the state. I'm down in the Philadelphia, Pennsylvania area where it's only rain. So we've got a variety of weather tonight. I'd like to introduce and welcome our presenters. But first, I want to welcome every single person who is on this webinar. You're interested in palliative care is extremely important. We know through the women that we talk with who have breast cancer, particularly a later stage breast cancer, how important palliative care is. And your interest in learning more about it is a real tribute to you and an understanding of how important palliative care is to the people that we serve. First, I'd like to welcome our presenter, Dr. David Wenner, who is the Chief Medical Officer of the Hospice of Central Pennsylvania. And Dr. Wenner, as Medical Director, is responsible for the delivery of patient care and the medical oversight of both Hospice of Central Pennsylvania and long-term care. Now, it's important to understand that this is something that's offered all across the state. There are different areas of the state, but the Hospice of Central Pennsylvania is an outstanding one and one that we're partnering with for this webinar and some other activities. Dr. Wenner is a Penn State graduate. He did his medical education in the Philadelphia area, and he's practiced family medicine for over 24 years. He became the Chief Medical Officer of Hospice of Central Pennsylvania in 2011. And every day, Dr. Wenner sees patients and their families in their home, and that's an important part of palliative care. So I'd like to welcome Dr. Wenner, and secondly, I'm going to introduce both of them, and they'll come on sequentially, is Dr. Maria Olender. Dr. Olender is the Associate Medical Director of Hospice of Central Pennsylvania, and she's a graduate of Franklin and Marshall College and the New Jersey the Medical College of New Jersey. Additionally, Dr. Olender received a fellowship from Penn State Hershey Medical to study hospice and palliative medicine. So I'd like to welcome both of them, and I think we can get started. Dr. Wenner, Dr. Olender.
All right, Dr. Olender, I'm going to switch my screen to you.
Hi there. Thank you so much for that warm introduction. This is Dr. Olender. We would just like to thank all of you so much for the opportunity to participate in this amazing discussion. I hope that my screen is visible, and here we go. So we will start our discussion on palliative care and breast cancer. We're going to be focusing on symptom management and patient-focused care. So our objectives today are: we will help you understand how patients with breast cancer are coping with their disease and understand the basics of palliative and hospice care. Hopefully at the end of this presentation, you will understand when the transition time is appropriate for hospice care, understand how symptoms are managed in breast cancer and what treatment strategies are utilized, and then identify some end-of-life pharmacologic treatment options that we typically use in the hospice setting to help our patients at the end of life. So at the start, we're going to focus on, this lecture is kind of focused in two different avenues. The first being, what is palliative and hospice care, and the second being symptom management. And I wanted to start off with just a general overview. So palliative care is a patient and family-centered care. This optimizes the quality of life by anticipating, preventing, and treating suffering. Palliative care is able to be involved throughout the continuum of illness, and it addresses not just physical suffering, but intellectual, emotional, social, spiritual needs. And they help facilitate patient autonomy, access to information, and also choice about medical decision-making. Particularly in the breast cancer population, it is tremendously valuable to have choice about your medical care because there is so much choice. And we feel that it's so important to involve palliative care early. So palliative care is actually appropriate at any age and at any stage of diagnosis. So we, as palliative care doctors, help address pain and symptom management. We will address emotional and spiritual support. Advanced care planning will be reviewed, and we oftentimes will assist with goals of care setting. So this old versus new approach that you see on the right-hand side of your screen is actually pretty interesting. So previously, before the real strong advent of palliative care, there was a focus on life-prolonging care, and then there was the focus on Medicare covering hospice or, insurance covering hospice care. And there was really no continuum of care. And, to us as palliative docs, we felt that that was incredibly abrupt because patients were almost left stunned to see, we're not focusing on disease treatment anymore, but now they're telling me I want to go on hospice. And it was very confusing for patients. And so we feel that it's a much better approach now to involve the help of a palliative care team concurrently while the patient is seeking life-prolonging care. In doing so, they're able to involve a team of specialists early on and help the focus when it needs to shift instead of life-prolonging care to pain and symptom management with the help of a palliative care team, then focusing in, again, through the continuum of hospice care, and then following that, bereavement care for the loved ones of the family members involved in this journey. I feel that that is a much more continuous approach to providing patient care, and patients and families oftentimes will tell us that they wish they had involved palliative care earlier when they were, struggling. So this is a very significant, change in the atmosphere of medicine. So palliative care focus in breast cancer is unique. Breast cancer patients typically have a wide array of options that they can pursue for their treatment. And oftentimes these are going to include chemotherapy, radiation therapy, surgical interventions. They each carry their own particular benefits, but they also certainly carry their own risks and side effects. So the goal with palliative care is to work concurrently with the cancer specialist. So we will help target the symptoms that are making our patients feel uncomfortable to allow them to have a better experience through whatever treatment plan they pursue. Those symptoms can include anything from pain, nausea or vomiting, constipation, depression, anxiety, spiritual distress, fatigue, etc. And specifically for patients with advanced or metastatic breast cancer, the team will pursue a potentially larger role in advanced care planning, and they may provide a tremendous amount of assistance with goal setting and coordinating grief support and family counseling for loved ones. That's tremendously valuable, and I feel that that is a critical element that allows for the family to be involved in ongoing care of the patient. Oftentimes, families are left pretty out of the loop, unfortunately, and I feel that that will be a huge benefit to families to enroll them to assist with that care planning. And that's how palliative care can help with facilitating those discussions, particularly with complex or advanced breast cancer patients. So Dave, do you want to take this slide?
Yeah. So we'll sort of just think about palliative care and sort of keep that in one side of your head. For many patients, those patients that are toward the end of their disease, they have documented progressive disease. One of the things that really I think palliative care affords them and their families is a bridge. And as Maria mentioned earlier, this upstream referrals to palliative care, I think, serve many different purposes. But for those patients that really are having documented progressive disease, then the scary H word or the hospice word, it gets discussed. This is a definition, if you will, from the National Hospice and Palliative Care Organization. The takeaway for us really is hospice care is using the same tenets that we use in palliative medicine, but for those patients, they're in a situation that their prognosis is typically felt to be less than 6 months. So hospice care isn't, as some people seem to believe, giving up. It really is focused on those patients that we know have progressive disease, that the treatments that they had been undergoing with the hope of improving and prolonging their lives have reached a point where really either they're having significant negative side effects or their quality of life is being affected. So hospice care is something that we always think about. It's amazing many times when we do palliative care consults, the patient and their families during these meetings will have questions about what is hospice care and when will I know that it's time for me to think about that. So again, just to think a little bit about hospice care in the place that it fits. So we'll move to the next slide then, Maria.
So this gives you a bit of an overview, and the real main differences between hospice and palliative care are that hospice care is designed, just as Dave said, for a patient who has a terminal or untreatable illness with an anticipated prognosis of less than 6 months. Palliative care is designed for a patient, again, at any age and at any stage. So a patient can receive palliative care at the time that they are diagnosed with their illness. Both care philosophies are focused on a team-based approach, and both philosophies are focused on aggressive pain and symptom management, with the goal being the best quality of life that the patient can attain. Patients on hospice care typically don't seek return to the hospital, but if we need to have them return to the hospital for symptom management, we absolutely can do so in hospice care. Patients on palliative care can be seeking curative treatment and oftentimes are, and oftentimes they do require to go back to the hospital for acute admission, potentially for symptom management, but potentially for issues related to their disease process.
Maria, this is Dave. The other thing that I would point out for those on the call, not all palliative care programs offer the same list of options in terms of the kinds of services, the kinds of supportive services that a particular patient may need. So I think for those listeners on the call that may be making suggestions or recommendations to others that they're working with or caring for, I think it's important to identify with the palliative care team or the palliative care organization that you may be making a referral to as to what additional supportive type services would their organization be able to provide.
I think that's a great point, Dave, that oftentimes when I see a patient for a palliative care consult, I may not be the most important element to that patient, meaning that we will have a social worker or a chaplain address the most important issues to that patient. And, you know, I as a physician may offer some assistance with symptom management, but their suffering, their pain, their distress may be related to a symptom that I'm not the point person for, and that is absolutely okay with me. Oftentimes I will find that my social workers or my chaplains or even my music therapists can be ideal to help patients with symptom management that might not be addressable with medications, with pharmacologic approaches. And that's the value of having a team-based approach to palliative care. Oftentimes I can make sure that my patients have their needs addressed in a multifactorial way. So in bridging that, when we talk about a patient who has received a palliative care, consultation and they've been followed by palliative medicine, there will be times where a physician will recommend that a patient be transitioned to hospice care. And that's a question that is on the minds of many of my patients who I do see for the initial palliative care visits. They say, when is the right time to transition to hospice? As Dave said, that can be a tricky question. We oftentimes find that when patients are no longer candidates for disease-directed therapy, or that there has been significant disease progression despite aggressive treatment, that will be the point that they may have a valuable discussion to address changing to hospice care instead of just focusing on further disease-directed therapies. Typically, the goals of care at the point where a patient is considering hospice care will shift. Instead of focusing on aggressive disease-directed therapy, meaning that instead of focusing on chemotherapy or radiation or further surgical intervention, when a patient is considering transitioning to hospice care, they may want to focus more on pain and symptom management instead of curative treatment. And so what's needed to actually initiate a hospice care evaluation? So a physician order, typically physician order will say, hospice eval and treat for whatever terminal diagnosis that is, be that breast cancer or pancreatic cancer or what have you. And to physicians to certify that prognosis is less than or equal to 6 months if the disease follows its natural course. I think we were having some technical problems here, guys. Bear with us for a second here. Okay, I think we're back on. Looks like we may be still having some technical problems. So I'm going to move on to the next slide.
Dr. Wenner,
Okay.
this is Natalie. If you'd like me to, oh, it just switched to the next one. So.
Yep. There we go.
Okay.
Okay.
Let me know if you need me to switch. We also have it up on our screen as well.
Okay, got it. So I will just review a couple of the things that hospice care can offer. And so this is for patients who are receiving hospice care, meaning that they are focused on pain and symptom management. Their prognosis is anticipated to be less than 6 months. So patients who receive hospice care for their terminal disease process will receive nursing care. They can opt to receive home health aides to help with, let's say, bathing, dressing, light meal preparation. They have a social worker who can help them discuss advanced care planning or address any family dynamic needs. They have trained chaplains available for spiritual support. They also have trained volunteers that can assist with the family in providing care for the patients and acting as a emotional support individual. Certainly physicians to assess the patients in their home and provide ongoing medical care. Medications that are related to the terminal prognosis are covered. That means that hospice will pay for those medications. And that includes things like pain medicine, medications for nausea or vomiting, for constipation, for fatigue, for anxiety, etc. Some hospice organizations do offer music or pet therapy. Some offer art therapy, palliative massage. Certainly pharmacy support is always available. And bereavement care is one of the critical components of hospice care, and that is offered for patients' families 13 months after the death of a loved one, for 13 months rather. And that's a tremendous support system for families, knowing that they can speak with a bereavement counselor. We have bereavement support groups. Those are tremendously valuable to assist the loved one in that period of transition when their loved one has died and they are looking for some support. So,
Great.
Dave, would you like to start with this one?
Yeah. So we're going to get into now sort of talking about various symptoms and sort of the goals of palliative care in terms of, like the name implies, the word palliate means to reduce or lessen. And so treating symptoms and understanding the potential symptoms that may arise with various diseases, in this case breast cancer, is really critically important for the palliative providers to be able to provide guidance and in some ways anticipate questions and concerns that the patient and families may be, if not verbalizing, certainly thinking to themselves in terms of what might I expect as time goes by. So next slide, Maria.
Okay. Sorry, guys. I know that we're having some audio issues with this conference. It's a little bit delayed. Looks like the connection has been lost. So let me see here. Dave, if you'd like to
yeah, I can move along. Yep. So we're now going to go through a number of different symptoms, the first one being pain, but the other symptoms that Maria and I will touch on will be symptoms that will include dyspnea, anxiety, nausea, vomiting, constipation, and fatigue. Again, these are symptoms that are not necessarily unique to breast cancer patients, but certainly they are common symptoms that we encounter in many malignancies, but certainly they're symptoms that we see commonly with breast cancer patients. I think one of the important messages that I think listeners need to understand is this this term pain. So to many physicians, pain is pain, and in some ways the focus always is the patient is having pain, therefore it must be physical pain, and the treatment for that physical pain then ends up being some type of analgesic. I think it's important to understand that pain actually can be caused by a number of different factors, including physical, psychological, social, and spiritual pain. So attempting to understand sort of what is at the root of the patient's pain, what type of pain is it, really, it sounds like a simple thing to treat pain, but in actuality, treating pain is very complex. And without knowing sort of what type of pain the patient is having, you're not going to be able to give them really the kind of care that they're really looking for. So this whole idea of palliative care and using interdisciplinary approaches is very important. As Maria said earlier, a patient may be having a spiritual pain, and certainly in that case, using an opioid to treat their spiritual pain is not the treatment. The treatment would be to pull in one of our chaplains to be able to work with that patient to address any spiritual concerns that they may have. Yeah, go ahead, Maria.
You got it. Yep. So here is kind of an overview of what we would do to just initially assess a patient for pain. There are different types of pain that we oftentimes encounter, specifically from an oncologic disease process, sometimes somatic pain, pain that is, let's say, a metastatic lesion in the bone. That can be constant, achy, localized pain. That can change with movement. Sometimes we'll see visceral pain, meaning a deep organ. So if, let's say, they've had a metastatic disease, throughout the belly, and they have this deep, achy, cramping, very non-specific pain that they are just in agony about, and they just can't describe. They can't put their finger on it. That can be described differently than a neuropathic pain, which really takes the nerve component and describes it as a shooting, a burning, a stabbing. Those types of pain are, physical pain characteristics that we oftentimes will assess specifically for our patients with oncologic disease to help target our pharmacotherapies. For patients who are nonverbal, now this is a question, if you have a patient who is, let's say, nonverbal because they are, under heavy sedation, but they can actually still express pain, I will assess them for signs of facial grimacing, for brow furrowing, wincing. How is their breathing? Are they tachypnic? Are they vocalizing? Can I console them? Is a family member at bedside, and can they console them? I oftentimes will obtain my history from not just the patients, but their nurses, their caregivers, their family members who are at bedside. And that will often give me a very global assessment of pain that may not just be assessed by my history taken from the patient alone. I find that very valuable. When we take a pain history, this is the standard, OPQ, RST, but more importantly, I like to ask my breast cancer patients, how is their pain affecting their ability to work or to drive? Can they participate in family activities the same way, or is their pain influencing their ability to do so? What about engaging in intimate relationships? I find that question is oftentimes overlooked, and often it's actually because of provider embarrassment, but that is a tremendously important element to consider for women, and that question should be asked, and I think is very important, particularly for women going through any stage of breast cancer. Intimate relationships can be very different after a breast cancer diagnosis, and it's important to assess how that is, how that breast cancer is affecting their life in multiple facets. On top of that, how are your patients able to perform all of their activities of daily living? Are they able to dress by themselves? Can they bathe? Do they need assistance with toileting? How is their sleep involved? Do they have difficulties with eating? All of these elements are so critical for me to understand their overall quality of life. And that question is always on the top of my mind when I'm assessing a patient. I am hoping to understand what elements I can address to improve their quality of life. So we'll talk about choosing analgesic therapies. So we talked about options to target pharmacologic approaches. So when I target my patient's physical pain, I'm thinking about numerous different options. Those options, they can include the gamut. So Tylenol is an option that I'll schedule a gram TID. I'll consider using high-strength NSAIDs if I have severe somatic pain. Neuropathic agents like gabapentin or even an SNRI like Cymbalta or venlafaxine can be very helpful to target both physical pain as well as emotional and anxiety. Those kinds of emotional pain oftentimes are concurrently found with physical pain. And I'll oftentimes use Cymbalta or gabapentin to help target both of those elements. Steroids are one of my favorite medications because they oftentimes can help with inflammatory pain, but also they will improve energy, they'll increase appetite, they can help tremendously with pain control, and I'll oftentimes use low doses first thing in the morning and not dose after about 2 p.m. to avoid changing their sleep pattern. When we talk about other medications for analgesic therapy, opiates are one of the mainstays of pain management. However, they should be chosen very carefully and with consideration of renal and hepatic function. And so what I tell my fellows and residents when they rotate with me is that start low and go slow. So that means that start low doses of medications, particularly opiate therapy for opiate-naive individuals and older adults who have changes in their renal and hepatic function may benefit from starting much lower doses than you would typically start for, a vigorous 45-year-old female who is coming in with, let's say, metastatic disease from her breast cancer. If you're looking at a female that's in her 80s or 90s and has very significant pain but is opiate naive, my dosing regimen may be very different for that patient because I'm going to be very sensitive to her hepatic and renal function. Special circumstances that we can address, specifically renal failure and liver failure. So morphine, I typically try to avoid in fulminant renal failure. The reason being that toxic metabolic buildup may occur as a result of morphine buildup, and patients will have very significant side effects such as morphine-induced myoclonus or delirium, and those circumstances do not compute with the quality of life. So they are things that I want to avoid. So I will consider instead the use of oxycodone, hydromorphine, fentanyl, or even methadone. For patients with liver failure, also morphine potentially is less preferable. There's a lot of question on what's the best opiate to use. Some people say fentanyl, some people say methadone. I say start low and go slow. For both of these potential complications, you're looking at low doses, titrating gradually upwards, and reassessing your patient frequently to assess if they've had a successful improvement in their pain. And if necessary, you may need to use adjuvants such as your, NSAIDs, your steroids, your SNRIs, SSRIs, to help manage your physical pain. I oftentimes find that I need to use 1 to 2, perhaps even 3 different multimodal approaches for physical pain, but that can be very beneficial because you're using a multifactorial approach. So this is something I find very critical, particularly with opiates. You're going to find that there's a lot of side effects that can be potentially serious. And some of the main side effects we discussed here, so respiratory depression. Everyone is always worried about respiratory depression with an opiate. However, it's always preceded by sedation. So in order to avoid the potential risk of respiratory depression, start low and go slow. So start low doses, increase them slowly, and always monitor the patient after they've been given a titrated dose, an increased dose. So constipation is one of the most common side effects from an opiate. It's caused by decreased bowel motility. I always prophylax with senna, and that is one of my kind of gold standard medications to help with constipation as a result of opiate therapy. Nausea after opiates usually is transient after several days. Sedation can occur when you initiate a new opiate or when you increase doses. Usually patients will acclimate to that after a couple of days. So I always caution my patients, if I've needed to increase their opiate, I warn them, please make sure that you are safe in your home, that you have someone to care for you if you need it, if you're not driving, so that you know how this will affect you, because this dose increase may be a significant change in your ability to perform all of your tasks, daily living activities, etc. Myoclonus is also one of the potential signs of an opiate toxicity. It's rare, but I have seen it with very high doses. It's it's an element that when you see it, you'll never forget it. You'll see intermittent muscle twitching. And what I say here is that you need to dose reduce your treatment. So reducing your opiate dose, potentially rotating to a different opiate, and consider adding a benzodiazepine like Ativan to schedule that. So we run the risk here of potential seizure activity, and I'd like to avoid that at all costs. So adding a benzodiazepine, rotating my opiates, those are some of my common practices when we do see myoclonus. And this is a possible opiate toxicity that I do see at end of life as well. Delirium, meaning a change in mental status that can acutely occur. Oftentimes I see this when an opiate is initiated in a very critically ill patient and they are very, very cognitively impaired. And we oftentimes wonder, did the medication do this? Is there underlying disease process doing this? Often it's a combination of everything that's going on with that patient. But we have to be very sensitive to delirium because opiates are deliriogenic. So those with metabolic irregularities, particularly elderly patients, or those who are chronically critically ill, we have to be very cautious with dosing. So again, low doses, starting low and going slowly upwards. And lastly, urinary retention. This is one that we oftentimes forget about. This can occur after an opiate initiation. So if I have a patient calling in that says, I really can't urinate all that easily, and they just started me on a low dose of morphine, I don't understand what's going on. The light bulb goes off and says, hey, listen, I'm wondering if anyone told you about the risk of urinary retention here. So we always evaluate for bladder distension on exam if that's a concern. And usually that does resolve. Of note, any concerns about constipation should very seriously be addressed when you're looking at urinary retention. Oftentimes I'll find that the bowel is not prophylaxed and we have severe constipation concerns. And if we treat the constipation, urinary retention and urination can also improve. So Dave, you want to address this?
Yeah, non-physical pain. So we talked a little bit earlier about the role of other team members on the palliative team to address potentially those patients that have symptoms. They appear to be in pain, but yet you determine that actually it's likely not to be physical pain. The other thing that certainly happens quite often is those patients that have both physical as well as non-physical pain components. So while you're addressing their physical pain, things are improving, but they're still uncomfortable. They're still their symptoms are still not well controlled. Obviously, then one needs to really think about the other possibilities in terms of non-physical pain, anxiety, spiritual needs, psychosocial concerns, other things that they are concerned about within their home, with their disease and its impact on their family unit. Thinking about non-pharmacological pain interventions, meditation, art, music, pet therapy, aromatherapy, Reiki therapy. Those are all things that certainly have a role in the management of those patients that may have non-physical pain. I think the next one up is dyspnea.
Yep. You want to talk about that one, Dave?
Yeah, no, that's, let me talk a little bit about dyspnea, the sensation of breathlessness Certainly very common. One would think about this certainly in those patients that have breast cancer that may have metastatic disease to their lungs. There's also sort of this interplay or dance, if you will, with dyspnea in the next slide that I'll have Maria talk about, which is anxiety. And there is this interplay that many times goes back and forth between dyspnea and then anxiety and how to manage the both of those. Certainly patients that have had previous chemo, certainly radiation therapy are apt to have problems with dyspnea. Much like we use opioids for the management of physical pain, opioids really are extremely also very beneficial in the management of dyspnea. Patients, certainly in addition to having metastatic disease to the lung, if they have an underlying anemia or have comorbid conditions such as interstitial lung disease or COPD, likely to also have some degree of dyspnea. This idea of managing opioids for their dyspnea as well as benzos, things like Ativan, Xanax, many times the combination of the two is what's necessary. There's this idea also of medical air. The idea that moving air actually helps patients feel less dyspneic. So sometimes even just an oscillating fan in the room for those patients that feel short of breath can be extremely beneficial and helpful.
So for patients who are at the end of life, and this is one of those end of life pearls, we will oftentimes use concentrated opiate therapy. So opiate concentrate, meaning a 20 milligram per ml concentrated solution. Morphine comes in a 20 milligram per ml, and oxycodone comes in that strength as well. We use the concentrated solutions because the volume of medication is much smaller, and it allows us to dose escalate if necessary, but still keep the volume of the dose at a reasonable level. Those can be given sublingually or orally. And also we oftentimes will occasionally encounter the process where a patient can't take anything by mouth. We'll be able to use, IV or subcutaneous administration, even rectal administration of opiates. But the cornerstone here for end-of-life care patients who have severe dyspnea is opiate therapy and occasionally benzodiazepine therapy. We'll talk about the management of anxiety. Like Dave said, there is a strong interplay between the sensation of breathlessness and anxiety. One feeds into the other. And when we have a patient who has anxiety, be they end of life or not, I want to assess the elements that are comprising their anxiety. So again, a multimodal approach utilizing the physician as well as the spiritual support team, the social worker, counselors, et cetera. Those are all critical for anxiety assessment. Anxiety can occur in the breast cancer population from a numerous different amount of reasons, from underlying psychiatric disease, from acute and chronic pain, from adverse side effects from drugs, from metabolic causes, possibly from existential, social, or spiritual suffering. So in terms of the medical use of SSRIs, SNRIs, benzos, those should be considered alongside the use of non-pharmacologic interventions. So I think you're all sensing a pattern here that we as palliative doctors really value the benefit that pharmacologic agents provide us, but we also value the non-pharmacotherapy approaches. Sometimes for my anxiety patients, I find that the meditative practices, spiritual support and counseling are oftentimes just as effective, if not more so, than pharmacotherapies. For my patients who are in the hospice realm, I tend to avoid the use of SSRIs and SNRIs. And I'll simply put it this way. Most of my patients in hospice may not live long enough to gain the benefit of those medications. I oftentimes see that they need to be on those medicines for at least a month or two, if not more, to achieve a steady state in their system and to have those medications be as successful. So oftentimes I'm using agents that are much faster acting, and those are my benzodiazepines. And I will also, of course, use my non-pharmacologic interventions. It's not to say that I can't use SSRIs or SNRIs in my hospice patients. It's just you're looking at time frame very specifically. And so if my patient I'm estimating has severe anxiety, but their prognosis, meaning the time left that they have to live, may be in the short days to weeks range, my SSRIs are not going to be my number one choice. It's going to be my benzodiazepine agents and my hospice team members, basically. Now, for, like I said, end-of-life patients, we will consider the use of a benzodiazepine, and specifically Ativan is what we commonly use. We'll see that that is also available in a concentrated solution. Ativan comes in an intensol, which means it's a concentrated liquid, comes in a 2 milligram per ml solution, and usually my starting dose is about 0.5 to 1 milligram by mouth or sublingually, about every 6 hours as needed. If I have a patient that is severely anxious or has had benzodiazepines in their past, they've been on them, and they potentially may need stronger doses, that is also very reasonable at end of life. We can dose escalate that. And again, the volume of solution is such that it is very reasonable to give at end of life because it's such a small quantity. So this next slide is incredibly busy, and I actually love it because it shows you how nausea and vomiting can be incredibly complex. So nausea and vomiting is our next topic of discussion, and that is something that I find very common in my palliative and hospice population. And if we look at this, we're seeing kind of major areas of input. And so if we start from the top left, we'll see that there are input centers from the brain, so high CNS involvement. Down, we'll see vestibular involvement. Also, these are all going to the integrated vomiting center, or basically the emesis center of the brain. Now, when I have a palliative patient tell me, I'm really nauseous, I will attempt to find out the etiology of this nausea, and that oftentimes has me asking about 1,000,001 questions. But I do this so that I can target my therapies very specifically, and you'll see why. A patient who has nausea and vomiting coming from, let's say, a GI tract will have a very different treatment approach compared to a patient who has an increased intracranial pressure, let's say from a metastatic lesion in the brain. So my next slide, you'll be able to refer back to the slide as needed, but my next slide targets a couple of areas where we as palliative doctors will use specific medications very purposefully and for specific etiologies. So one of my favorite medications to use is actually off-label. It's a dopamine receptor antagonist, and that is haloperidol. That is Haldol. You will see that commonly in the psychiatric population, but I actually use it very off-label for nausea. And the reason I do so is it's a strong dopamine receptor antagonist. My usual starting dose is about 0.5 milligrams orally, about every 4 to 8 hours. I'll usually go on the longer spectrum, probably every 6 to 8 hours when I start off. And we can increase that up to 2 milligrams or more if needed. And again, off-label use, but very effective. And I typically warn patients about the side effects, grogginess, sleepiness, etc. And this, obviously, in addition, you can use prochlorperazine, similarly a dopamine receptor antagonist. It's compazine. And I'll usually use that about 5 to 10 milligrams orally, about every 6 to 8 hours as necessary for nausea, vomiting. Interestingly, we have suppository form of antiemetic medication. So compazine suppositories, very effective, certainly removes the need for anything by mouth. A nauseous patient will hate you if you constantly tell them to take something by mouth. So we appreciate that in hospice and palliative medicine. We tend to use a lot more of the rectal route if we can. If the patient is really nauseous and prefers not to use the oral route, that is absolutely fine. So the next one, again, my favorite medication here, dexamethasone. Corticosteroids are critical, and usually for a patient with a suspected, let's say, end-of-life patient with a malignant bowel obstruction or an increased intracranial pressure, I will oftentimes dose my patients at about 2 to 8 milligrams. Usually 4 milligrams is my standard, and I'll usually give that every 8 to 12 hours. If necessary, if they have very severe disease, that can be given every 6 to 8 of 4 to 8 hours. Again, this is something I use commonly for patients who do have a metastatic brain lesion, let's say, or a malignant bowel obstruction. Serotonergic agents are commonly seen with your Zofran, your Aloxi. Those are available in, particularly Zofran as an oral disintegrating tablets. Those can be very effective for patients who are currently receiving chemotherapy because they're targeting one specific receptor, the serotonin 3 receptors. You're going to see that those agents are very effective in patients who are receiving active therapy with chemo. I oftentimes find that Zofran is actually constipating, and so I will avoid the use of Zofran if my patient is not on chemotherapy, and I'll oftentimes reach for Compazine, Haldol, potentially dexamethasone instead. And then lastly, benzodiazepines are actually useful in one specific type of nausea, and that is anticipatory nausea. Again, low starting doses. And anticipatory nausea I find in my cancer patients who will be so nauseous because they will anticipate being nauseous prior to getting chemo. So I'll oftentimes tell them, listen, take a 0.5 milligram dose about half hour to an hour before you are going to be sitting in that chair so that your nausea can be targeted and your anxiety can be targeted as well. So I think we're picking up on a pattern here that anxiety, dyspnea, nausea, all of these are interrelated. And we, as palliative docs, think globally about symptom management. So we try to use one medication to cover multiple different symptoms. And this is a perfect example where benzodiazepines can target a couple of different things at the same time.
We talked earlier. Yeah, we talked earlier about constipation being a common and often, in many cases, undertreated. Causes are variable. I think it is very common for us in the field of and hospice care to, whenever we're starting to use opioids for patients that are having dyspnea or pain, we will marry, so to speak, them with something, a bowel regimen, because not only are we trying to treat pain, we don't want to have them be more uncomfortable from constipation. Obviously, there's some other things that from a non-pharmacologic standpoint could be done, increasing fluid intake, exercise, or trying to stay as active as they can. And then on the bottom of the slide, some typical stimulant laxatives that we typically would use when we are using an opioid. I think one of the other bowel medications that commonly we see used is Miralax. And while it can be used effectively for constipation, one needs to be very careful because in order for that to really be effective, one needs to still be able to be drinking a decent amount of fluids. So those patients that are really having more problems with their fluid intake, Miralax may not be the best choice for the treatment of their constipation.
For my end-of-life care patients, I will oftentimes avoid the use of Senna altogether, avoid Disacodyl by mouth, just because they are really not able to take a lot of things by mouth anymore. And in that circumstance, we will use Disacodyl suppositories. And my goal is usually to have a bowel movement about every 72 hours. The question I get a lot from my patients as well, or my patient family members is that, my wife is really not eating in about a week, but we're still giving her, morphine, but she's not eating. Do we really need to have her have bowel movements? And I say yes. And the reason is that if you have severe constipation, even at end of life, it can precipitate severe pain, distress, delirium even. And so I oftentimes will recommend using that Disacodyl suppository every 72 hours, even if they're not eating, just to make sure that our bowels are moving. The body still produces waste, even if it is not taking in. And so in order to prevent those potential complications, I'm always very vigilant about prophylactic bowels at the end of life even. So next, we have a review of fatigue. So fatigue is interesting. It's one of the most common symptoms for breast cancer patients, and it's particularly common in those receiving chemotherapy. About 80 to 96% of patients report they have severe fatigue. However, fatigue from cancer differs from other manifestations of fatigue. So typically, this is not alleviated by sleep or by rest. It's typically of greater duration and severity. Your patients will complain of fatigue from doing moderate activity, and it's not associated with a significant level of exertion. It's disproportionate to that level of exertion. And it's oftentimes accompanied by a very severe amount of distress. And so that interplay of anxiety is oftentimes very common here. And so the assessment of fatigue should be multifactorial. So the questions that I ask are, how is your attention? Is your concentration impaired? How is your motivation to accomplish tasks? Do you have any generalized weakness? Is your sleep impacted? Are you sleeping too little, too much? Is there a change in your sleep pattern? How about emotional reactivity? Are you finding that you are reacting to things that make you annoyed much more easily than you were before? Is your memory impaired? And how are you able to accomplish tasks? Those are some of the questions that we oftentimes will ask when assessing a patient for fatigue. Again, this multimodal approach is key to a successful treatment. In the palliative world, we like to use psychostimulants as a potential adjuvant to fatigue. Sometimes a small dose of Ritalin, like 5 milligrams, can be very effective to target cancer-related fatigue, and it has minimal amount of side effects. But I will use additionally some SSRIs, potentially even Wellbutrin or corticosteroids, again, to target fatigue, which may respond very differently than a typical fatigue. This is, cancer-related fatigue, again, very different than a typical standard fatigue assessment. And particularly here at the end of life, you're going to want to counsel your patients that it is expected and often non-reversible. And this can be incredibly emotionally draining and very difficult for family and loved ones to understand. It's critical to understand that the process of fatigue at end of life is a potential part of that dying process that most, if not all, patients go through, and that should be normalized and expressed as something that while we may not be able to change, we may be able to assist in providing a better quality of life despite my patient's fatigue. So it may be valuable to talk about, let's say my patient has a really significant fatigue during the hours of 9 and 11. And she wants to get up out of bed, but she just can't do that in order to spend time with her husband. I'll encourage her to spend those hours sleeping and resting, and then have a planned period of activity where she knows that her fatigue is not as severe. So she may need to get some errands or tasks done later in the day. And I would encourage that so that she knows, let's say 3 to 4 p.m. is actually an optimal time for me. I would say utilize that time, make that your time to get things done as much as you want to. That's the idea of energy conservation. I want you to conserve your energy for the time where you're going to be able to utilize it the best. And lastly, we in the palliative world are very cautious about word choice. So we like to use terminology that is inclusive. So you'll oftentimes see palliative doctors avoiding terminology such as withdrawing care or nothing more can be done. Using that kind of terminology almost stings to me. It focuses the shift away from a curative measure, but when focus shifts away from a curative measure, you should not consider that as a withdrawal of care. I find that in terms of changing my word choice, that I acknowledge how distressing or frightening something can be, but I oftentimes will address the change of goals as we're focusing on a new plan of care. We are focusing on aggressively targeting your symptoms as opposed to aggressively targeting your disease. I focus on aggressively managing your pain instead of aggressively curing your cancer. Acknowledgement of that distress can be incredibly empowering, and we will empathically acknowledge that to my patients who are suffering, that empathic acknowledgement I find is, it can open the door for more conversation. Just the question of, tell me more about how this is affecting your life, can be incredibly inviting for a patient who has had a lot of her, I would say a lot of her life changed in irreparable ways. That tell me more question can open the door for a lot of insight, and it helps me as a doctor understand how I can help my patients better. And I think it helps patients connect with their medical providers on a deeper level.
Okay.
So we have some references here. We'd just like to thank everyone for their participation and the tremendous support that we've received for this lecture. And we'd like to thank the PA Breast Cancer Coalition for allowing us to talk with all of you. So thank you so much.
Thank you. And I wonder if we have some time for at least a few questions from our participants. I believe they've been sent to Natalie. Natalie, do you have any questions?
Yes, we do have a few. We have a specific question here about chemo-induced neuropathy. And this attendee says, I've been through gabapentin, Lyrica, nortriptyline, Nucynta, and the scrambler treatment, wondering if there's any other help for CIPN.
That's interesting. So it sounds like you targeted the main treatment strategies. I wonder if the approach to a, sometimes I'll find a TCA, meaning a tricyclic antidepressant medication, might actually be an effective adjuvant to neuropathic pain. Some of those things like nortriptyline, I think you mentioned. There's other elements that we have encountered. So potentially even carbamazepine comes to mind. Now, we would have to, if we have some more information, we can get back to you some, maybe some recommendations. But sometimes I find my, anti-epileptics like Tegretol, carbamazepine, or other anti-epileptics might actually be helpful to target neuropathic pain. Some neuropathic pain is incredibly difficult to target. And we know that some opiates potentially can help with neuropathic pain, but again, that is usually limited. But oftentimes, if I'm having significant amount of trouble targeting neuropathic pain, I'll also consider the use of methadone. Methadone is my kind of silver bullet when it comes to neuropathic-induced pain. Potentially has the utilization for pain related to, pain that can be treated with an opiate, but methadone has a unique component that can target neuropathic pain. So that's one that I would consider in this circumstance.
Excellent, thank you.
The other thing that I was going to suggest, because I don't know the dosages of the gabapentin that the patient had tried. Certainly, gabapentin has a very wide range of dosages. You can go the whole way up to 3,600 milligrams a day for gabapentin. So the patient may have already tried higher doses, but if they weren't tried on escalating doses of gabapentin, that would be another consideration.
Okay, great. Someone else asked, what about medical marijuana?
Oh, that's a great question. Yeah, we actually encounter that question more and more each day. So this is a really interesting field. I think both myself and Dave are very excited about when there will be more research, when there will be more data coming out. We as providers think that any avenue to help our patients with pain and symptom management would be welcome. The sad thing is that we don't have a lot of data to support the use of medical marijuana. And so prescribing that is not actually something that we can do. So as The state laws in Pennsylvania are changing, so there are now physicians who are licensed to be recommending physicians for medical marijuana. So that's a whole process that we can actually spend an entire webinar on. But that is an adjuvant medication that can be considered for pain control. It also potentially has benefits for nausea, fatigue, vomiting, mood. So there's options there. I think we're all really excited to see when there will be data to support its use. And, what we say is if you are interested in that therapy, do your research, look into a dispensary that has a pharmacist who's actually able to sit down with you, have a consultation, evaluate you. I think it's useful to have an understanding of what the therapy can do and what it can't do. But we are really looking forward to getting more data on its usefulness and what kinds of symptom control we can achieve through the use of medical marijuana.
Another question?
Yes, along the same line, someone asks, what about acupuncture?
Oh, yeah. So acupuncture is a great addition to a pain regimen. So I'll tell you a brief story. When I was a fellow completing my fellowship at Hershey Med, I got the amazing opportunity to rotate with a physician in the VA who actually did acupuncture therapy for her patients. She did this for patients who had chronic pain, who had elements of severe dyspnea related to COPD. So she would actually come up to our inpatient hospice unit and perform acupuncture on some patients who had refractory dyspnea as a result of severe COPD. And it was tremendous. My patients would experience a very significant improvement in their dyspnea. They had less anxiety. They told me that they were able to sleep better. So I think it's a very valuable approach. If you have a practitioner who is skilled in this technique, I think it is tremendously valuable. The downside is there are not that many skilled practitioners available, particularly in isolated parts of the country. So if you have a provider that that does this type of therapy, I think it's a wonderful addition. I know myself and Dave have both talked about taking a training course for acupuncture therapy. And Dave, I think, where is that offered? Is there one in Boston, I think California?
Yeah. Harvard has one. Harvard has
one.
Yeah.
Do we have any other questions, Natalie?
Yes. And before we have one more at this point. We have quite a few asking if the slides will be available. So I just want to let everyone know that they will in fact be available. This is actually being recorded. So probably tomorrow afternoon, we will have this on our website at pabreastcancer.org. You can watch the webinar again, pause it wherever you like and play it. And then also when the webinar ends, someone had asked about continuing education hour. There will be an evaluation that pops up and you can take that and then you will get a certificate for your continuing education hour. That's for nurses in Pennsylvania. So just want to remind everyone of that. But we do have a question about insurance, and someone asked, do most insurances pay for palliative care?
That's an excellent question. I think most are now viewing this specialized field of palliative medicine as extremely beneficial and have taken it upon themselves to pay for palliative care consults. There are certain codes that we use in the area of palliative care, but my advice would be that to check with your insurer just to see whether or not palliative consult and palliative care follow-ups would be covered. I think we're seeing more and more insurers that are indeed paying for palliative consultative services.
And may I ask you to say something about insurance coverage for those who may be on Medicare and or Medicaid?
So certainly palliative care consults and follow-up services are covered under Medicare, and there is coverage under Medicaid as well.
I think that would be very helpful for our folks to know, because many people who, are candidates for palliative care, and certainly at the hospice level, may well be on Medicare or Social Security Medicare. And we might want to mention that there is special access to Social Security disability and Medicaid coverage for those who have breast cancer. And it's a compassionate access route that's much shorter than the normal route. And it's for people who are under normal Social Security age. So we have people who lose their regular insurance coverage, but there's another route through Social Security, Medicaid, compassionate access. Any other questions?
That concludes the questions that we have from attendees directly for this evening.
Well, I'd like to be so thankful to Dr. Wenner and Dr. Olender. This has been very informative. I've never heard any detailed description of palliative care, particularly palliative care and breast cancer, and this is really opening up a whole new area for us. I know through the women who call us that palliative care is sometimes available in their area and sometimes not. So I think that if more patients ask for it, more will be available. And thanks to your good work, I think that will happen. So again, thank you so very much for doing this webinar on palliative care and breast cancer. And thank all of the participants who have been with us this evening, because I know that what they have learned will be of great help to women who have breast cancer. Thank you all.
Thank you.
Thank you.
Thank you.